introduction. Good evening to everybody. First, clear the one confusion. I am Sandeep Tak, not Tank. Uh, it's misprinted, I think,
My
there.
apologies.
Yeah, it's misprinted there. We had a very excellent, interesting talk about SGLT2 inhibitors in the just previous session. Now it's a bit of a boring thing like hypertension. We all treat hypertension day in and day out, and there are so many guidelines and everything. Uh, let's see how can I make it a bit interesting. Uh, Topic is guidelines for the management of hypertension in context to the type 2 diabetes. Uh, does the guidelines are adding more confusion or not? We know hypertension is a common comorbid condition in a patient with a type 2 diabetes. Almost 30 to 40% of the type 2 diabetes have a pre-existing or associated hypertension. That's why it is very crucial to check blood pressure routinely in all individuals with the type 2 diabetes, or in fact, any person visiting your clinic for the first time. Uh, a different thing about the diabetes and hypertension is that diabetic patients are more likely to have a that non-dipping pattern, nocturnal pattern. Typically, when in the night blood pressure drops by 5 to 10 millimeter of mercury, diabetics may be having a non-dipping or a reverse. There may be a bit of a rise in the blood pressure in the night time. And the ideal way to confirm it is the ambulatory BP monitoring or 24-hour BP monitoring, or alternative way is home BP monitoring. Managing diabetes, hypertension in diabetes is challenging because already these patients are on the so many drugs, and adding or further increasing the drugs, at times patient complains 150-90 BP है sir, ठीक है चलता है, what to do? So that makes you reluctant to add or increase the drug or change the drugs. But hypertension is associated with significant ASCVD, heart failure, and nephropathy risk in a patient with type 2 diabetes. Even simple 10 millimeter mercury reduction in the blood pressure is associated with almost 12% reduction in the overall complications of the diabetes. Mortality is reduced by 15%. Risk of MI is reduced by 11%. Microvascular complications reduced by 13%. These are the absolute number. In the previous discussion, what we were talking about, the relative risk reduction with the SGLT2 inhibitor of to the tune of 20%, 30%. That is the relative risk reduction. These are the absolute risk reduction to the tune of 10 to 15%. In the patients with the diabetes, just controlling the blood pressure, good blood pressure control is going to reduce the risk by 10 to 15% mortality risk. Diabetes and hypertension we know has a common risk factors like the you have a genetics, you have a basically insulin resistance, you have obesity or dyslipidemia. All these are the common risk factor for the diabetes and hypertension, and ultimately that leads to the cardiovascular disease. And we just talked about the hypertensive heart disease or heart failure with the preserved ejection fraction. That starts with the basically with the hypertension. Hypertension in early stage leads to the LV dysfunction, and even there may not be any left ventricular hypertrophy when you are doing echo. Stage 2 or degree 2 is when you have a LV diastolic dysfunction and you have a LV hypertrophy, but still patient is not symptomatic. But technically these are the patients who have a heart failure with preserved ejection fraction. Degree 3 is you have a clinical heart failure. Patient comes with the symptoms of the pleural edema or shortness of breath. Again, even at this stage, if you do ejection fraction, it may be normal, 55%, 60%. And when we see the heart failure with reduced ejection fraction, that is a late stage, heart already dilates, ejection fraction goes down, and that's a very late stage to treat the heart failure. So that's the importance of treating the hypertension aggressively in your patients with the type 2 diabetes. And we have several major organizations which has released the hypertension guidelines that includes the specific recommendation for managing hypertension in a patient with diabetes. You have a plethora of guidelines from the various international bodies. I will just be very briefly discussing touching each of them, and finally what we can make out of them. There are Western guidelines like ADA. Latest says that the target BP should be less than 140/90. 130/80 is appropriate when they have a high CVD risk. And first line of therapy they suggest is AS or ARBs in these patients. and monitor for the orthostatic hypotension when we are treating elderly patients with the hypertension. ACC and AHA criteria are a little bit more stringent. They want BP to be less than 130 or diastolic less than 80 in a patients with the type 2 diabetes. And they have a little bit of difference in as far as the guideline is concerned. Calcium channel glucose, ACE inhibitor, ARBs are there as the first line, but thiazide, ACC recommends thiazide as a first line of the therapy. ESC guidelines, ESH guidelines, their target is a little bit different. 140/85 for the patients with the type 2 diabetes. ACE and ARBs are the preferable drugs, and more stringent if the person is younger patient. Or if person can tolerate BP of less than 130/80, then it should be preferable. ISH guidelines, International Society of Hypertension, key recommendations, BP less than 140/90 in the most patients. ACE inhibitors, ARB, CCB, or thiazide diuretics. Basically, you will see all this pattern 140/90, 130/80, and 130/85. That's the most of the time. NICE guidelines 140/90 is the recommendation. First line is the ACE ARBs. Same, nothing changed. Canadian guidelines 130/80. WHO guidelines 140/90. And the first line therapies are the ACE inhibitors, ARBs. But the WHO guidelines stresses what is important for our country. Focus on the low cost, widely available medications which has a global applicability. Whenever we are using particularly thiazide diuretics, it increases the cost of therapy because these are the chronic long-term therapies that is the issue. So these are the summary of VP targets in the diabetes in the most of the Western guidelines which I have discussed. Coming to the Asian and Indian guidelines. South Asian Federation suggests BP 140/90, and if the CVD risk is higher, 130/80. First line therapy ARBs, and calcium channel blocker or thiazide diuretics can also be used as an alternative. Chinese guidelines stringent less than 130/80. Korean 140/90. Basically, you see same thing, almost similar pattern, 130/80. And this is the guidelines of the Indian Society of Hypertension. They say optimal blood pressure should be less than 130 systolic or less than 85 diastolic. High normal is 130/90, and 85 to 89 is the diastolic is the high normal. Grade 1 hypertension is 140 to 160 systolic or 90 to 99 diastolic, and grade 2 160 and above, and diastolic 100 and above. These are the ISH guidelines. So these are the summary tables of basically Asian and Indian guidelines. So what we make out of all these is because ultimately Dr. Anuj Mishra is sitting here, who has made a lot of guidelines and on the hypertension also, released on the hypertension also. So basically what we have here is most of the guidelines suggest that we should be having BP 130/80, 140/90. That's again, that difference of 10 millimeter mercury is a big difference. 130/80 and 140/90 looks like almost normal. But once we talked about the absolute number, 10 millimeter mercury reduction in the pressure reduces the overall mortality by 15%. So that's the question: where should we be? What should be our target? When should we be starting the treatment, and what should be our target of the blood pressure? That's the interesting question. So basically, I settled on the RSSDI guidelines for the management of hypertension and type 2 diabetes, and I thought that that is the optimal thing. They suggest that normal blood pressure is systolic less than 120, diastolic less than 80. It's elevated, if it is 120 to 130 is systolic, or more than 80 diastolic. Stage 1 hypertension, 130 to 139 systolic, and 80 to 89 diastolic. Stage 2, 140 to 180. Stage 3, more than 180. And diastolic is concerned, stage 2 is 90 to 120. And more than 120 is stage 3 hypertension. So basically, there are more steps in the RSSDI guidelines. So you can basically label, check who is the highest risk, on the highest risk, and who is going to benefit most with the reduction of the blood pressure. And this is the threshold for the starting the treatment. Uh, Once you measure the blood pressure in the office, three readings, average of last two readings, and once you have settled that this is the blood pressure of this your patient, how to treat it? Uh, they suggest that between 18 years to 80 years, any systolic blood pressure over 140 should be treated. Any diastolic blood pressure more than 90 should be treated. Above 80 years, systolic blood pressure threshold they have increased to 160. Reason I think is once the person has reached the age of 80, one thing is life expectancy is much less. And if we are using too much of a drug, we are going to cause a postural hypotension, fall, and overall poor quality of life in these patients. So that threshold has been changed. But diastolic, if it is more than 90 in elderly, you should be treating it. Diabetes with the CKD patients, if person is having a microalbuminuria less than 30, you can have a target of 140/80. If it is between 30 to 300, target is again stringent, 130 to 8. Less than 130 systolic and less than 80 diastolic. These are the basic indications of the individual drugs classes based on the guidelines and various clinical studies. Uh, because as you will be seeing, I haven't mentioned beta blocker in all those guidelines and list because Dr. Anuj Mishra would be talking about that next. Uh, uh, Here, these suggest that if the person is having a heart failure, beta blocker can definitely be included in your treatment protocol. Otherwise, in the most of the conditions, ACE, ARBs, and calcium channel blockers are good enough. So, as per the RSSDI guidelines for the management of hypertension in a patients with type 2 diabetes, they have advised three classes of drugs: ACE, ARBs, calcium channel blockers, or diuretics. Preferred ARB, there says it's telmisartan, or you can use agilsartan. Uh, why preferred is mentioned here, I don't know. But telmisartan, we often most common antihypertensive drug used is telmisartan, much more than the even losartan nowadays. And if your blood pressure is not controlled with the ARBs, you can add the calcium channel blocker. That is the cilnidipine or amlodipine. Cilnidipine has an advantage that it has a less of epidural edema, so that's one advantage and has a better blood pressure control as compared to the amlodipine. ACE inhibitors can be specifically be used if patient is not responsive to the combination therapies or ARBs, but we often avoid because many patients develop intractable cough or not able to tolerate. Diuretics, they suggest, to be used in the patients with the resistant hypertension or patients, elderly patients. When you want a mild drug, use the diuretic. So ultimately, what are the recommendations? Individualize the treatment, look at your patient, what are the other comorbid conditions, whether the patient had a prior stroke or whether patient has a prior MI or patient has a heart failure. If patient has heart failure, definitely beta blocker is going to come. ACE inhibitor or ARB is going to come. Previous stroke, ACE, ARB plus calcium channel blocker becomes again an important thing. So individualizing the treatment is important. But otherwise, a standard patient, diabetic, hypertensive, ACE, ARB, in combination with the calcium channel blocker is good enough. And combination therapy usually is preferred because most of the patients require more than one drug. If systolic BP is more than 20 millimeter mercury, usually you require one or more drug to control the blood pressure. ARB may be preferred over the ACE inhibitor in diabetic patients with hypertension, and telmisartan, agilsartan, they recommend. That's the grade B evidence. In the patients with the risk of CVD, renal disorder, cerebrovascular disorder, combination therapy again preferred because these are the high risk patients. High risk patient, we want a blood pressure systolic less than 130 or less, diastolic 80 or less. Uh, Calcium channel blockers may be preferred in a patient who has a basically previous history of a stroke. Calcium channel blocker has shown to reduce the recurrence of the stroke. And the use of the beta blocker and diuretics must be avoided in routinely in a patient with standard patients with the diabetes. But if they have other conditions, comorbid conditions like heart failure, definitely they are going to be useful. So, take home message basically is while there is general agreement on the importance of the BP control in diabetes, specific targets still are fluid and preferred therapy varies slightly across the guidelines. But what I can say is whenever we are talking about a person with the high risk of CVD, who is the high risk of CVD? Hypertension with comorbid conditions. If person is having a two comorbid condition, that is high risk of CVD. Patient is having a obesity, patient is having a cardiac problem, patient is having a dyslipidemia. These all are the patients with the high risk patients, and almost 50% of our diabetic patients fall in this high risk category. So ultimately, we should be settling around the target of 130 to 80. Thank you.